So let's talk about some diagnostic tests for diabetes type 1 and 2. If a fasting blood sugar, which means that there's been no caloric intake for 8 hours, is greater than 126, that's a cause for concern. With the glucose tolerance test, we have the patient drink 75 grams of glucose in a solution, and if their blood sugar goes over 200, that's a cause for concern. The threshold for the A1C number is greater than 6.5. And any time of day, just a randomized glucose test that is greater than 200 is cause for concern. Most of us are very aware that without insulin, our cells can't use or receive the glucose that we eat. But I wanted to point out two of these, and that is the ones that relate to the liver, because one of our other exemplars is cirrhosis. So insulin signals the liver to stop the release of glucose. It also stimulates the storage of glucose in the liver as glycogen. One of our other exemplars is cirrhosis, which is related to fatty liver disease and metabolic syndrome. So perhaps later I'll tie that in. I really like how simple it's put here. Insulin works to decrease the blood glucose levels. Glucagon works to increase the blood glucose levels. With type 2, we have the option of the oral hypoglycemics like metformin. With type 1, we don't. We only have one treatment solution. I wanted to point this out and probably will mention it again, but in stress, surgery, or sickness, the insulin demands go up. So here is our expected ranges for blood glucose. So I like to commit these two things to memory, and that is that 1 unit of rapid acting insulin will dispose of 12 to 15 grams of carbs. And then to correct high blood sugar, 1 unit of insulin is needed to drop the blood glucose by 50 milligrams per deciliter. Key terms we have here is the basal bolus. The basal or background insulin dose is usually constant from day to day, and it's to make up or replace the insulin lost overnight. And sometimes it's given in the morning and the evening. And this is the slower acting insulin types. From this, I think one of the most important things as far as what could be pulled into the test is going to be these peak times. I remember those in that we have a 30 to an hour and a half range, and then we almost touches the 2 to 4, which then does in fact overlap 4 to 12. So we have a 30 to 90 minute, 2 to 4, 4 to 12, and then down here we have no peak. And I always remember peaks and plates need to coincide, so the patient needs to have a plate in front of them right before that peak sets in. Here's a really simple graphic of what we did in lab last week. I really like how they laid it out. We go from cloudy to clear, keep it in the clear, withdraw, and then go back to cloudy. Can't forget this. We only give regular insulin is the only one we give IV. And then of course clear is the short acting, cloudy is the intermediate. The additives, what makes it cloudy is the substance that extends its like peak or onset and duration. So that's how I remember. This is just perfectly clear because it's just straight insulin, so to speak, and then this has the additives. I see two things on this PowerPoint slide, and that is that mixing foods together in the same meal slows down the overall glycemic load. Mixing a starch with a protein and a fat slows down the absorption and the glycemic response, but also we have fiber that has an influence on the glycemic response. And then this one could be kind of tricky if it was select all that apply, and that is that a raw food like raw cabbage, for instance, versus cooked cabbage has completely different glycemic response. With the raw foods, they take more work for your body, and therefore they have a lower load. So just something to keep in mind, that on the exchange calculation system that we did in lab, where you're supposed to trade this for this for this, and the food groups, which, by the way, I don't understand that, and I really want to watch a video. Perhaps I'll put a playlist up after this with something on that, because I'm afraid we're going to get a question on that. But anyway, so the difference, well, actually, these are the similarities in how we treat a patient with DKA and HH&S. Completely different disorders. DKA is mainly associated with type 1 diabetes, HH&S type 2. So this one really was a stumper. I had to do some research on this. If the patient has low potassium level, we're actually going to delay the insulin treatment until we get it back above 3.3. There is a relationship between insulin and potassium, in that insulin not only takes the sugar into the cell, it also takes the potassium with it. And then the opposite reaction can happen, where we flood the blood with more potassium when it comes back out of the cell. So I just wanted to point that out. And with potassium, we're always monitoring like EKG. We're taking vitals often, because potassium and the cardiac function are really, really intricately connected. Let's see some of this. We're monitoring the electrolytes every 2 to 4 hours. That makes sense. We've got the cardiac monitor. We're assessing their mental status, and then we're going to do these monitors too. Hyperthyroidism. We've got way too much T3 and T4, and thyroid hormones stimulate most of the systems in the body. So that really makes sense that we have heat intolerance. Our metabolism is too fast. Makes sense that we've got weight loss, because we're burning a lot of energy, and all that hyperactivity in all the systems could be leading to the diarrhea. The thyroid gland's working overtime, so it's got some hypertrophy and heart palpitations. Everything, like I said, is revved up. Let's see, but then this doesn't make sense, and that's easy to remember when something doesn't make sense, at least to me, and that is that we have the higher metabolism, but we have weak muscles. There's also some eye problems, and so we call that exophthalmos. And one thing I remember from another study guide is that the NCLEX sometimes asks, what do we do as nurses with exophthalmos? And that is that we have to keep their eyes moist when they're sleeping, and so we actually will teach them to tape some gauze over their eyes, or tape their eyelids shut, if that's that sounds so funny and so weird, and if I saw that on the test, I'd think it's a joke, but it's a real thing. And if you didn't know, this is what a normal woman with normal eyes looks like. Let's talk about the thyroid disorders, and we'll start with hyperthyroidism. We've got elevated blood pressure, elevated heart rate. We've got facial flushing. That makes sense. That goes with the elevated blood pressure. We have a fast metabolism and weight loss. We have tremors. That goes with, that all makes sense to me. And the heat intolerance, of course. So if we have an underactive thyroid, hypothyroidism, we're going to see sensitivity to cold from a slow metabolism. We're going to see tiredness, activity intolerance. We're going to see weight gain from a slow metabolism, constipation, and depression. Let's remember that Graves' disease is associated with overactive thyroid, hyperthyroidism. And then all within that same cluster, we have these eye problems with the hyperthyroidism. So this is really interesting how the beta blockers, which are blood pressure meds, the LOLs, actually have use in treating hyperthyroidism. So they counteract the effects of the increased thyroid hormone, but they don't actually, change the levels. So we're going to watch their blood pressure, heart rate, EKG, I guess it treats the fast heart rate, the palpitations. And of course, we monitor the pulse before giving. Sometimes, with a really bad case of hyperthyroidism, the patient gets a thyroidectomy. A big thing here for nurses is to understand that there is a potential for airway impairment because the surgery is right there in front of the trachea, around the airway. Swelling, stuff like that can lead us to an ABCs issue. We're going to, of course, monitor for bleeding. That's with almost every surgery. We're going to assess their pain. Yeah. Semi-Fowler's position, and we're going to keep the head and neck supported because that's where the incision was. That's where the surgical trauma is. Discourage them from talking. That will be easy to do. Assess their voice. I don't exactly know what that means. Potential hypocalcemia. Oh, yeah. Whenever there's work done on the thyroid, the surgeon can accidentally affect those little bitty parathyroid glands, which are hugely important for the calcium level in the blood. So we're going to be watching that like a hawk. Let's see, we've got the drugs, the thionamides and the propylthiouracil, or the PTU. I've heard people say it puts the thyroid under, is how they think of it. And then methimazole. Adverse reactions: fever, sore throat, mouth sores, skin eruptions, and unusual bleeding or bruising. Ask the provider about using iodized salt and eating shellfish. These foods contain iodine and may alter the effectiveness of the drug. Okay, that's important. We're watching for signs and symptoms of the reverse, where the drug has taken the disease to the other end of the spectrum. So we've got unexplained weight gain, fatigue, cold intolerance, and we're going to notify the doctor. This is huge. This is a huge safety issue. So with the thionamides, the PTU, and the methimazoles, pregnancy. Uh-oh. That could be a select all that apply. Let's see. There's a risk of liver disease. So we're looking for all of those common liver dysfunction signs and symptoms. And then we can always just like completely destroy the thyroid if we need to with our radioactive iodine therapy. Let's see. Obviously, it's indicated for that. I don't even know what that means. If you don't, we should all just go look it up. Let's do that. Hypothyroidism. Yes. In this case, we've done too much. We've destroyed the thyroid gland too much, and we took it the opposite direction. Problem swallowing. That's a big one to remember. A thyroid crisis. Yeah, that's deadly. Never heard of that in my life, but okay. This is the thing, like the radiation exposure to others. There's the obvious things like no hugging, kissing, sharing utensils, stay away from pregnant people, use your own bathroom for a few weeks. There's those things. It seems like I'm leaving some out. We should all just go brush up on that. Here we go. I like how this is organized. All right, so with the methimazole, we have drug-induced hepatitis and all the symptoms that go with hepatitis. Let's see. Both of these are first-line anti-thyroid drugs. Let's see. Hay fever, skin rash, headache, nausea, vomiting, and paresthesia go with methimazole. Here we have our pregnancy warning, but this I didn't know, and I'm glad I caught this and pointed it out. The PTU is the preferred drug while pregnant. That's an important distinction to make because the others are hazardous to the fetus. Let's see. Here's a key point. With the thyroid drugs, abruptly stopping them can lead to all kinds of rebound reactions that, in the opposite direction, that can actually kill someone. All right, let's talk a little bit about the parathyroid gland disorders. I wish I had a little diagram showing the anatomy of it, but these are the little guys. Oh, there it is. These are the little guys on the back of the thyroid gland. They're very small, very fragile, but extremely important. Before we talk about that, I want to point out that parathyroid hormone increases serum calcium in the blood. Calcitonin regulates it, but it also decreases it. It sends that calcium back into the bones. So I think of this as a little seesaw. The parathyroid hormone increases, calcitonin decreases the serum level. The parathyroid gland produces and secretes PTH, which controls the levels of calcium in the blood. I really like understanding this because we have two inverses here. Calcium going up, phosphorus going down, calcium going down, phosphorus going up. So for me, the way I remember this is the hyperparathyroidism raises the calcium. Hyper, raise. Hypoparathyroidism lowers it. Let's see. With the hyper, we have stones, bones, moans, and groans, which include mental irritability and confusion. We've got bone or skeletal pain because we have too much calcium leaving the bones, going into the blood, which can lead to fractures. Too much calcium in the blood, the body tries to respond by secreting it in the urine, which then could lead to precipitate of calcium kidney stones. How we treat it. Give phosphates, calcitonin, IV, bisphosphonates. I don't know what those are. Because they've got the GI issues, we're going to raise their fiber and moderate their calcium intake. Let's see. With the hypoparathyroidism, that's the one that happens if it's accidentally harmed or removed in surgery. Radiation can do the same thing. We've got tetany from, we have all the same symptoms of low blood calcium, which is the tetany, the muscle cramps, the tingling, hypotension, anxiety, irritability, and depression. And if you don't know these, you're going to have to know these eventually. We've got these two clinical signs of low calcium, which is where a blood pressure check causes their hand to torque up, and then that's Trousseau's, and then Chavostics, which is where you brush someone's cheek and they involuntarily smile. Here we have the classic manifestations of hypothyroidism. We've got a slow metabolism, which leads to the cold intolerance, slow digestion, fatigue, weight gain. Thin hair and brittle fingernails makes us ugly. Dizziness, probably from the hypotension. Skin changes. Poor girl. Poor memory, ringing in the ears. So that's what we're going to see with hypothyroidism. Associated with hypothyroidism is Hashimoto's disease. And what it's special for is that it's an autoimmune disorder where the body has destroyed its own thyroid gland. Yeah, so the body thinks that it's a foreign body or an invader, and so it creates antibodies to destroy it. It comes with all the classic signs and symptoms of hypothyroidism, and then it's more common in females. There's a genetic factor. You're at increased risk if you have other autoimmune disorders. It comes with a goiter. That's a common complication. Heart issues, depression, and other mental health issues, reproductive issues, and let's see. There it is. Our reproductive issues, and then the myxedema coma, which is rare and life-threatening. Since tests like to cover some of the most critical points, I wanted to talk about thyroid storm. A thyroid storm is a medical emergency. Let's see. In rare cases, it is rare, An undiagnosed or poorly controlled overactive thyroid can lead to this serious life-threatening condition. The sudden flare of symptoms can be triggered by an infection, pregnancy, not taking your medications, and damage to the thyroid gland from actual trauma. The symptoms that go with this, and this could be on the test bigly, is a rapid heartbeat, high temperature, diarrhea, yellowing of the skin, severe agitation, and loss of consciousness. Let's see. Here's what we're going to, here's what our findings are going to be with the myxedema coma. We've got low blood salt level or sodium levels, and then low blood sugar, lactic acidosis. That's going to influence like respirations and things, respiration count. Patient's going to be cold. Oh God, that doesn't sound good at all. They're going to have some like orientation and cognition issues, and eventually coma and death if we don't seek treatment quick enough. With our thyroid hormones, we want T3 to be between 80 and 220. I have no idea what Ng per deciliter stands for. With T4, we want it to be between 4 and 12 mcg, and then the TSH a half to 5. I have no mnemonic for that. You're just gonna have to memorize that the old-fashioned way. So just to review, which one of these parathyroid disorders has the stones, moans, bones, and groans mnemonic? Hyper. This is probably important. With hyperthyroidism, the T3 and T4 go up, but the thyroid stimulating hormone goes down. With hypothyroidism, T3 and T4 go down, and thyroid stimulating hormone goes up. Okay, so with Cushing's and Addison's, these are both disorders of the adrenal cortex, dealing with the hormones, the glucocorticoids, the mineralocorticoids, and the sex hormones. With Addison's, how are we going to differentiate these on the test? Well, with Addison's, we need to add more steroid hormones. The patient's deficient. With Cushing's, they have too many. And so with Cushing's, a patient, if they're very unfortunate, they're going to have all the signs and symptoms and look a lot like that, which is terrifying. And then with Addison's, all the signs and symptoms would look kind of like that. So with Addison's, we have this special risk of an Addisonian crisis. So I'll just read this off. We have profound fatigue, dehydration, as in like shock levels of dehydration, renal failure, rapid respirations, low sodium, low potassium, blue skin, cyanosis, and fever, nausea, and vomiting. We're going to be working quickly on their fluid resuscitation and giving them more steroids to make up for what they don't have. With Cushing's, a lot of times it can be caused by just a long-term use of cortisol medications like prednisone. Sometimes there's disorders that require that, and it's just kind of unavoidable. But there could also be a tumor in the adrenal gland, which is causing, too much production of these steroid hormones. So with cortisol in particular, cortisol is a stress hormone. It's a fight or flight hormone. One of its jobs is to raise the glucose level. So that's going to be something we tie into that. It's going to cause the fat storage, the funny fat storages. That's kind of a longer term fight or flight response that bodies have built into them. And the high blood pressure, that's a common fight or flight thing. So on the exam, if we were given like a few signs and symptoms and asked to differentiate the two, it could involve things like potassium levels. So if we've got a tired, anorexic, which just means no appetite, hyperkalemic patient with some like unusual pigmentation of their skin, we're going to think Addison's. If we have a hypokalemic patient with elevated glucose, with moon face, truncal obesity, hypertension, we're going to think Cushing's. Hyperthyroidism and hypothyroidism, all on one convenient one-page study guide. So we have Graves' disease, also known as hyperthyroidism, and Hashimoto's hypothyroidism. If you could only remember one thing for each one of these, you're going to remember that with hyperthyroidism, we've got signs that are high and hot. With hypothyroidism, we've got low and slow signs. And then we have the thyroid storm complication. Both of these are really critical complications, is associated with the hyperthyroidism. And then the myxedema coma with hypothyroidism. Let's see, they're both, Graves and Hashimoto's are both autoimmune disorders. And logically, hyper has higher T3 and T4, and hypo has lower T3 and T4. One of our earliest signs of a thyroid storm is going to be the agitation and confusion. And then with the myxedema coma, it's going to be low respiratory rate. And this is saying that a priority thing for us to do is to have the trait kit already at the bedside because of that respiratory issue. And logically, we're going to have a lower temp, lower BP and heart rate, cold intolerance, but no heating blankets. Let's see. We're going to lower the patient's calories. We're going to give them frequent rest periods. We're going to increase the patient's calories that has Graves' disease to 4,000 to 5,000 per day, high protein and carbs. Not necessarily high fiber because they have a hyperactive GI system. And we want to lay off the caffeine. And to go over the meds that we use to treat hyperthyroidism again, we have the methimazole, which is definitely not safe for pregnancy. And then we have the PTU, which is baby safe. Let's see, adverse reaction to report is going to be the fever and the sore throat with the PTU. And then we have our favorite beta blockers that are also used in the treatment of hyperthyroidism. And then the radioactive iodine uptake is that's the treatment that actually destroys part or all of the thyroid. Let's see. Not for pregnancy. Stay away from crowds for 7 days. Have a dedicated restroom for the patient. Can't share food utensils and different laundry. Let's see, and then we got levothyroxine, which is a lifelong treatment. It's going to take 2 to 4 weeks for the drug to set in. They take it in the early morning on an empty stomach, not at night. If they have a really high blood pressure or heart rate, we're going to report agitation and confusion. And levothyroxine is baby safe. And we never abruptly stop it. So we'll go over steroids just briefly since they're used for COPD, asthma, and Addison's, all 3 exemplars for this exam. With the steroids, here are the precautions. We're going to report to the provider a 1 pound in 1 day or 2 to 3 pounds in a few gain. That's not good. That's excessive. We're looking for a low white blood cell count on steroids. That's going to become a priority. Blood sugar is going to increase on steroids. That's something to look for and monitor. It's going to make the bones weak. And then we have, I've never heard of that one, but okay, cataract risk. We're always going to tell the patient to slowly taper off any steroid. And if they are encountering any kind of stressor like surgery, we're going to increase the dose. With RSV, we're going to be looking at these signs and symptoms. We're going to have a clear runny nose, a dry cough, sore throat, low-grade fever, wheezing, nasal flaring, and rapid breaths. Low-grade fever being one under 100.4. So a key intervention that we're going to use with these young children that have RSV is we're going to use saline drops and a bulb syringe to keep their nose clear, because the airway is a big priority with RSV. I've heard that RSV is a contact precaution, but this is saying it's droplet, so I hope we don't get a question on what kind of precaution we're supposed to institute for RSV. Good luck if we do. I have to use these to remember which one is which, but I'll just let y'all read all that. This is kind of saying like the sound that vomiting makes is alkalosis. I didn't realize this, that renal failure usually is going to lead to acidosis. And hypokalemia is going to usually be accompanied by alkalosis. So let's see. The nurse expects which clients to be in respiratory acidosis. That's going to be the morphine overdose, sleep apnea patient, the COPD patient, the asthma attack, and the alcohol intoxicated patient. SIADH versus diabetes insipidus. So the SIADH patient is going to be soaked inside. They're going to have thick urine, which is going to have a higher specific gravity, which means it's over 1.03. The normal range for urine specific gravity is 1.005 to 1.03. And for our patients with SIADH, we are going to restrict their fluids. We're going to give them salt because they have low sodium. And we're going to give them diuretics. We're not going to let them drink a whole lot. And this is a time where we're actually going to use IV 3% saline. With diabetes insipidus, the patient is dry inside. When a patient is dehydrated, almost every single lab value is going to be elevated. So we're going to see high and dry labs. They're going to be incredibly thirsty but can't keep it in. They're going to be urinating a ton, and it's going to be very dilute urine with that low 1.005 specific gravity. Let's see, the treatment. We're going to be giving synthetic ADHs, and let's see, headaches are a priority, and monitoring sodium is a priority as well, because they're going to be prone to hyponatremia. When a patient is dehydrated, almost every single lab value is going to be elevated. So we're going to see high and dry labs. They're going to be incredibly thirsty but can't keep it in. They're going to be urinating a ton, and it's going to be very dilute urine with that low 1.005 specific gravity. Let's see, the treatment. We're going to be giving synthetic ADHs, and let's see, headaches are a priority, and monitoring sodium is a priority as well. And going back over the differences between DKA and HHNS, DKA patients are going to have fruity breath, not the HHNS patients. Let's see. Blood sugars are going to be elevated, but completely different zones. So HHNS is going to have over 600, and then the DKA is 250 to 500. There's going to be ketones with the DKA, but it's literally in the name, non-ketonic syndrome. There's not, the ketones presence isn't a thing with HHNS. Let's see. With DKA, dehydration is a really big deal. We're going to use normal saline to treat that. And when we're administering insulin, we're always conscious of the potassium, as we've talked about, and so we're actually going to include it with the treatment, with the DKA. And this says even if it's in the normal range, because chemistry tells us that there's going to be a shift in the potassium. This is an interestingly simple way to say it. DKA patients die from hypokalemia. HHNS patients die from hypovolemia. And here we have an example NCLEX question that asks, if a child is nauseous, not eating, maybe vomiting, do you still give insulin? Yes, we still give sick day insulin to prevent DKA because glucose is higher during times of illness. And to review the abnormal lung sounds, we will first start with wheezes, which are the musical. They have a musical nature to them. I just remember the band Weezer. That's how I connect it all. These are going to be connected with both exemplars for this exam, asthma and COPD. And then those meds are going to be used in conjunction. Wheezes are mainly heard on exhalation, but they can be heard in all the lung fields. And it comes from narrow airways, bronchoconstriction. Let's see. Rhonchi are low-pitched rattling and rumbling like snoring. They come from the bronchi, not the alveoli, and they are seen in bronchitis, COPD, pneumonia, and cystic fibrosis. So rhonchi, wheezes. Let's see, crackles are more with pneumonia, but usually CHF. So crackles are going to be the bubbly, liquidy sound. There's fine and coarse. They're in the lower lobes. And we treat that with diuretics. Let's see. Stridor can actually be heard after thyroid surgery. That's a big tip. Stridor is the high-pitched, harsh, inspiratory whistle. I believe that's that one that just sounds like the most disturbing. It's from a blockage in the larynx or trachea, and it's heard in the throat region during inhalation, and so that's associated with thyroid surgery. Here's how we manage acute diabetic complications. Let's say we have a blood glucose level of less than 70. We're going to use the rule of 15s, which is 15 grams of rapidly digestible carbohydrate like you would find in juice or soda or a glucose tablet. And let's see, we're going to give that and recheck the glucose 15 minutes after. We may repeat the process. If the patient's unconscious or NPO, we're going to give 25 grams of dextrose 50 IV slowly by push. No meals until we get the blood glucose in the right range, though. That's an interesting little nugget. I would think that it would be okay to just go ahead and feed them. And then so for severe hypoglycemia of less than 40 milligrams, we're going to give 30 grams of rapidly digestible carbohydrate and follow the same protocol above. Influenza. So influenza is primarily spread through droplets. So we're going to put the patient on droplet precaution. We're going to see fever, chills, malaise, muscle aches, headache, rhinorrhea, cough, and sore throat. An important patient teaching is going to be that the antiviral agent, let's see, it's oseltamivir. It has to be taken within 48 hours of the onset of symptoms, or else it's not effective at all. And what is the best way to prevent influenza? Annual flu vaccine. And let's not forget about transmission precautions. We already talked about influenza being a droplet, and that requires gown, gloves, and surgical mask. But then our other exemplar, tuberculosis, gets the big guns, airborne precautions. We're going to use negative pressure airflow, private room, gown, gloves, N95, and respirator. It's surprising, but evidence-based practice actually says that the patient only needs a surgical mask when they leave their room on airborne precautions. But the personnel get an N95 mask. So with diabetes mellitus, we have the low and the high blood sugar. I really like the way that this is worded. If the client is warm, if their skin is warm and dry, their sugar's high. If their skin is cold and clammy, they need some candy. So that really helps me remember like the symptom set of each one to not mix them up. Of course, we have the 3 Ps with hyperglycemia. Signs and symptoms of hypo is hunger, irritability, confusion, sweating, clammy skin, headache, shakiness, blurred vision, and we may see seizures and comas. When teaching patients about asthma, when they're taking their peak expiratory flow meter test, they're going to perform it 3 times and record the highest number, not the average. We're going to teach them to avoid the triggers if they are known. If it's exercise-induced asthma, they're going to use their bronchodilator 30 minutes before. They're going to need to know the difference between the short and long-acting asthma medications, and to make sure they use the right one, they're always going to need to have their emergency inhaler. And when we're treating an asthma attack, let's see, we're going to use, there it is. So let's see, this is for those 4 drugs: fluticasone, budesonide. The others I never heard of. Anyways, we're going to rinse our mouth out with water after administration, and always use the bronchodilator first and then the steroid after 5 minutes. Let's talk about some nutritional information about some of these exemplars. So with diabetes, we all know that they need to control their carbs, and they have a goal of getting their A1C below 7. This is something I had not heard of. Morning hyperglycemia, called SOMEGI phenomenon, is due to overnight hypoglycemia. And so to solve this issue, we're going to teach them to consume a snack with their nightly insulin dose. Let's talk about some nutritional information about some of these exemplars. So with diabetes, we all know that they need to control their carbs, and they have a goal of getting their A1C below 7. This is something I had not heard of. Morning hyperglycemia, called SOMEGI phenomenon, is due to overnight hypoglycemia. And so to solve this issue, we're going to teach them to consume a snack with their nightly insulin dose. And for our respiratory disorders, let's see. COPD patients, we want them to eat small, frequent meals, increase their fluids, have a higher calorie intake with higher protein, moderate to high fat, and moderate carbs. With cystic fibrosis patients, we're going to increase fluids, high fat, calorie, and protein diet. I've heard sometimes as high as 5,000 calories a day. They're going to need their fat soluble vitamin supplements. That's the A, D, E, and K. And very necessary that they take their pancreatic enzyme replacements. With someone convalescing from tuberculosis, we're going to need a high calorie diet, high protein, and nutrient rich to address the common weight loss and malnutrition that is seen with tuberculosis. So, to recap, with COPD, small and frequent, lots of fluids, high calorie, high protein. With CF, increase the fluids, high everything diet with their fat soluble vitamins and enzymes. And TB, they've got a malnutrition issue that we're trying to fix. So we feed them accordingly. With a Cushing's syndrome patient, we're going to restrict their fluids and sodiums, increase the protein intake as well as the calcium and vitamin D intake because of the common bone loss issue that we see with hypothyroidism, the low and slow thyroid disorder. We're going to increase the fiber and fluids to help them with their constipation. In hyperthyroidism, we're going to increase the calories because they're usually going to be thin with their fast metabolism. So we want to increase their protein as well. The three types: ventilation, diffusion, and perfusion. What's the difference? With ventilation, we're talking about the flow of air into and out of the alveoli. With diffusion, this is the actual exchange of O2 and CO2 between the alveoli and the actual blood. And perfusion is the exchange of the two gases between the blood and the tissues. So we've got in and out of the alveoli, alveoli to blood, blood to tissues. So our short-acting beta-2 agonists, which are going to be used for the asthma rescue drugs, albuterol, epinephrine, and levalbuterol. These beta-2 agonists, they come with the side effects of fast heart rate, palpitation, arrhythmias, hypertension, nervousness and anxiety, and insomnia. And so the difference between the short and long is we're going to use the short for the acute symptoms of bronchospasms and asthma, and then the long-acting ones are going to be preventing the bronchospasms that come with asthma, chronic bronchitis, and COPD. Second line drugs for use with bronchoconstriction or obstructive respiratory issues like asthma and COPD. It's going to be theophylline, which it has some serious adverse effects. We're going to be looking for the seizures, tachycardia, and dysrhythmias, and it also can get toxic very easily. And it is a bronchodilator, theophylline is. And it says it stimulates the central nervous system to promote bronchodilation. And then we have the good old-fashioned anticholinergics. These are the ones where you can't see, can't pee, can't spit, or poop. Let's see the names of these. I've heard of ipratropium, but not the other ones. But anyways, these drugs are used for tons of other indications too, like peptic ulcers and Parkinson's. But they actually do work to bronchodilate airways. A client that is dyspneic at rest has what class of dyspnea? Class 5. What class of dyspnea does a client get frequently winded from daily activities but can manage and stay independent? Class 3. Which lobes of the lung are best auscultated from the back, posterior side? The right lower and left lower lobes. What is the best kind of mask for a COPD patient? A Venturi mask, which is the type of mask that has the colored regulators. It allows for precise ratios of O2 and CO2. Tuberculosis sputum samples are done how to confirm a cure? On 3 separate days, a morning collection. COPD patients are driven to breathe from the lack of what gas? The lack of oxygen. Healthy people breathe because they have too much CO2. And so this is important because we don't want to over-oxygenate our COPD patients. They will just quit breathing. Cor pulmonale is right-sided heart failure. It is it comes from long-term high blood pressure in the lungs, and the right ventricle of the heart just weakens, can't keep up, and it leads to right-sided heart failure. Atelectasis is lung collapse. Signs of a collapsed lung: sharp chest or shoulder pain, shortness of breath, of course, nasal flaring, trachea deviation, and a new onset of a dry cough. What is the ventilator bundle of precautions? It's 4 things. We're going to elevate the patient's bed, daily sedation vacation, and assessment of their readiness to extubate, and peptic ulcer prophylaxis and deep vein thrombosis prophylaxis. So this is a cluster, a bundle of things that we do for people on ventilators. TB skin test in duration of 15 millimeters or greater is positive or negative? Positive. Patient may have tuberculosis. They may also have gotten the vaccine, or it's a past case of TB that has resolved. A TB skin test must be read in what hour window? 48 to 72 hours, and it is not valid if it's not read in that window. Hemoptysis is blood-tinged sputum, and it's one of the common signs of TB, and it's actually a differentiator. The tuberculosis signs and symptoms are night sweats, cough, hemoptysis, anorexia and weight loss, fever and chills, and shortness of breath, dyspnea. Night sweats and hemoptysis being the ones that are really red flags for TB. RSV signs and symptoms: clear runny nose, persistent cough, wheezing, low-grade fever, tachypnea, dyspnea, and retractions and nasal flaring. So retractions are where the 2 little spots around the clavicle like divot or go in when the patient is breathing. Let's see. So these are drugs for the treatment of tuberculosis. The adverse reaction for ethambutol is vision loss. It can be very toxic to the eyes, so we're going to report that immediately. if we see any vision loss with ethambutol. Considerations for pyrazinamide. Sun sensitivity. Rifampin considerations. Again, these are all TB drugs. Temporary red discoloration. Infertility is another thing. It's common. I guess I can't say common. It happens. Liver toxicity. So we're going to be looking for signs of liver toxicity with rifampin. Isoniazid considerations. We're going to tell the healthcare provider if there is increased thirst, urination, vision changes, easy bruising and bleeding, confusion, psychosis, and seizures with isoniazid. To me, that seems like the most dangerous one of the four. Isoniazid toxicity leads to acidosis or alkalosis. Acidosis. Normal saline, is it acidifying or alkalinizing? It's acidifying, pH of 5.5. Addisonian crisis leads to what pH? Blood imbalance, metabolic acidosis. So let's see, hold on. Isoniazid leads to acidosis, and then of course normal saline is acidifying, and Addisonian crisis is a metabolic acidosis. And this is a mnemonic that I saw somewhere about the most common causes for acidosis. It's mud piles. We have methanol ingestion, uremia, diabetic ketoacidosis, propylene glycol and ethylene glycol ingestion, iron overdose or isoniazid overdose, and lactic acidosis. And then, of course, the salicylates, which are the NSAIDs like aspirin. And so, again, these are causes for acidosis. What are the 4 S's that lead to DKA? Sepsis, stress, steroids, and skipped insulin. Hypoglycemia signs and symptoms. Nervousness, diaphoresis, weakness, lightheadedness, confusion, paresthesia, irritability, headache, hunger, fast heart rate, changes in speech, hearing, and vision. Those are signs of hypoglycemia. A female of average risk of gestational diabetes should get a glucose tolerance test between which weeks of pregnancy? 24 to 28. Earlier, if there's a higher risk of gestational diabetes. What are the diabetes sick day considerations? The client should continue their meds, including insulin, consume additional fluids, notify the HCP, monitor their blood glucose every 3 to 4 hours, and their urine for ketones. And they're going to do all those things on their sick days. A patient with diabetes mellitus that has a fever is concerning because infection is the leading cause of HHNS. DKA and HHNS differ in that level of consciousness and confusion are only a sign and symptom of which of those? HHNS. So mental state changes associate with HHNS and type 2 diabetes. True or false? HHNS has signs and symptoms of Kussmaul, breathing patterns, acidosis, and hyperketonemia. False. Those are all associated with DKA. A diabetic patient to take more or less insulin prior to surgery? More. Most common cause of DKA? Infection. Diabetics can moisturize their feet, except for which area of their feet? Between their toes. The signs and symptoms of a thyroid storm: hypertension, chest pain, dysrhythmias, dyspnea, delirium, fever, nausea, and vomiting. Signs and symptoms of a thyroid storm. The top 5 high glycemic index foods are sugary foods, sugary drinks, white bread, potatoes, white rice. And if we were to ask Elf, Buddy the Elf, he would say candy, candy canes, candy corns, and syrup as well. Compensated versus decompensated cirrhosis, what's the difference? When a patient starts having symptoms of cirrhosis, they now have decompensated cirrhosis. So compensated is where the body has made up for the issue and they have no symptoms. What is the patient teaching for the thyroid hormone replacement drug levothyroxine? Take it at the same time every day. Take it on an empty stomach 1 hour before meals, and it is a lifelong treatment. I remember from the lecture, Dr. Briscoe said that they would wake them up at 6 or 7 to give them their levothyroxine. Signs and symptoms of hypocalcemia: extremity tingling, tetany, circumoral tingling, and tremors. I forget which one of our exemplars associates hypocalcemia. What is the best dinosaur? Of course, the Stegosaurus. The nursing considerations for radioactive iodine uptake tests: they need to remove their jewelry and dentures. Afterwards, they're going to self-isolate for 7 days. Don't be pregnant and don't breastfeed if you're getting the radioactive iodine uptake test. The most common cause of hyperthyroidism is Graves' disease. The onset age is 20 to 40, and that's hyperthyroidism. The difference between primary and secondary hypothyroidism: primary is when the thyroid gland itself is the problem, not able to produce enough hormone. Secondary, the thyroid gland is normal, but the pathology relates to the pituitary gland or the hypothalamus. I feel like that's going to be on the test in some way, shape, or form.